So the next speaker will be Wim van Harten, professor from the Netherlands Cancer Institute.
Thank you very much. One moment I thought you would like to skip me, but instead of the lunch. But I will try to be as fast as possible in order not to be observed as a blockage for your well-being, so to say. What I try to do, and due to the presentations of a number of my previous presenters, I can go rather fast to the first part of my presentation. And what I will do is to show you not so much that there are inequalities, because that is sufficiently proven, but to show you two examples of studies, on one on drug access and one on socio-economic impact, and to see how we can use the OCI network to produce this type of data and to come to research, policy and research recommendation, and how well OCI is positioned to play a role in this field. What is also interesting, apart from the data that were already shown, is the Cancer Pulse site. I have no relation with the European Cancer Organization whatsoever, but it's very interesting an accessible site if you want to see some data on inequalities, and they are comparing countries like this. If you click on a certain issue like cancer drug availability, reimbursement, you can see graphs and data. And for instance, the reimbursement status of new oncology medicines is overall presented in this type of geographical graphs. And there is quite a difference between the various countries when it comes to the difference from EMA authorization to a coverage decision. And that differs quite considerably between countries. But what we have decided is that it is not, and this is the average reimbursement time. So you see I'm going very fast. But what is important is to realize that European approval, so market access, and national approval being a coverage decision, does not naturally mean that then there is also patient access, because patient access is the first time a patient receives the prescription in practice. What we decided is to interview a number of hospital pharmacists in 6 countries, and to see how the European approval date, the national approval or the coverage date, and the actual access is showing in practice. And then, of course, you also have reimbursed of early access schemes and trials going through this pattern, and that gives all types of options of patients being presented with the drug for the first time. And what we did was a survey and semi-structured interviews with these hospital pharmacists in 19 hospitals from 6 countries. We selected 6 medicines that were in different stages of market access, and we collected data points on EMA authorization date, coverage decision date, time to first patient access, showing from a file from the various hospitals, so not just from the coverage and the national agency, but the actual prescription and delivery in the hospital, and the context of the first access. And what we received was this type of overview. It was published in the International Journal of Cancer last year. And you see that from EMA approval, some hospitals, of course, have early access before EMA approval due to participation in trials. Some have then early access programs. Some have wait for a coverage decision, and in some hospitals, even a number of months or sometimes years is shown to be the difference between the coverage decision and the first access. And also the context of this first access is quite different. Sometimes you have early access programs, early trial decisions, and between the different countries you see quite different patterns on whether it is through, this one. Whether it is through the early access program, through national reimbursement, or through off-label use, that is also very different between hospitals and countries. So there is quite some inequality between and within countries when it comes to access to innovative treatments. And that is even further extended when you look at the subdiagnosis or tumor types that are relevant for these drugs per country. And again, you see quite a difference. This is Switzerland, Italy, Hungary, Belgium, Netherlands, and France. And you see, again, quite a different pattern which is even more complicated when it comes to the separate indications. So the conclusion of this study is that there is a large heterogeneity in patient access between and within countries. When it comes to relation with the EMA approval, we see an average difference between country and within countries of 2.1 years, from the first to the last patient in this study receiving the drug for a first time. But the range was between 1 year before EMA approval till 7 years after. So that is quite a difference in accessibility. But also, when you relate it to national reimbursement, there is an average difference per country of half a year. But again, there the range is almost 12 years in some countries between the first patient in a trial receiving a certain drug to the last registered patient receiving a drug for the first time as a covered reimbursement. And we see quite a difference also in early access programs and off-label use within countries. And what was interesting, that we see some trend that specialized hospitals like OCI-accredited cancer centers, that they were more likely to provide patient access prior to a national reimbursement decision than general hospitals not specializing. So we have a number of recommendations to improve equity in access to expensive drugs across Europe. First, to shorten the timeline from EMA approval to reimbursed access. You see that drug companies usually have tactics in terms of pricing policy, that they choose certain countries to launch their drugs before going to others, because when you use the list pricing system, the most expensive countries are normative for the less well priced countries, and then the launching policy of the pharma companies have serious influence on the access of patients throughout Europe. We see also that the patients in high medical need are not always receiving the treatments as a reimbursed coverage in all countries. So what we think is that countries should use each other's filing decisions on coverage and HTA decisions. And another issue is that within between and within countries, there's quite a difference on early access programs policies. In the Netherlands, that has led to the Society of Medical Oncology to make a national, what is said, drug access protocol. They reached consensus on what patients with what indication should make use of early access programs, and they made this information available throughout the country in a very accessible way. In this way, you can provide equitable access throughout your country, also for early access programs. And cooperation between different stakeholders is needed to tackle this problem. So what you see is that we see huge differences in actual patient access for new oncology treatments between and within countries, and there's a number of issues in which also professional societies can become active in order to tackle this problem. I will leave the issue of therapeutic infrastructure, but also on radiotherapy and other issues. You can see that there are huge differences, often economically driven, between countries in access to treatment, but that was already covered. Another issue is also related to expensive drugs, but also to other treatments, but also to the position of the cancer patient itself. What are socioeconomic consequences of a cancer diagnosis? You have a lot of factors that are of influence, and we recently published a paper in Lancet Oncology on what factors are all relevant. But we did a survey within the setting of European countries and OCI, on which we retrieved more than 2,500 patients responding in 14 European countries. And what we did is to explore the socioeconomic consequences for patients resulting from a cancer diagnosis, and to identify patient groups that may be especially vulnerable from financial toxicity. And this is, we did not yet involve the socioeconomic status of patients, because that is of course a very important factor, but this was just to make an inventory of the consequences of cancer. And we used the FIT score, a financial index of toxicity, and a number of additional questions on coping behavior, on employment changes, expenses that were added. And I will show you some of the results. They are still somewhat confidential, although we showed some in other congresses also, but the paper as a whole is still under review. First, what is very interesting is what is reported as monthly income loss. And here you see the countries indicated here: Netherlands, Spain, etc., France, Germany, Finland, Cyprus. And what is very shocking, to my opinion, is that the range of patients not reporting any financial income loss was from 34 to almost 50%. But also in very well developed countries, still the reports on income loss, and sometimes very high. There's also a range of 500 to 1,200 euros per month. So you see that even in well-developed countries, the income loss reported is rather impressive, and that was much more than I considered in advance. When it comes to added monthly expenses, you see also different scores per country, but this, for instance, on unreimbursed prescribed treatments or medication, and you see that this dark bar differs per country, but also here we see rather impressive results on the effects of cancer and cancer treatment on the socio-economic status of patients. Another issue is the additional payment and how did they do that in terms of taking external internal measures to improve their financial situation. And then we did simple questions like, did I use my savings? Did I spend less on luxury goods? Could I apply for financial assistance? And then also you see over the countries impressive rates of patients having to take measures to improve their financial situation. And a last slide which we wanted to show is what we call maladaptive coping behavior in terms of did you skip on any medical treatment related to your financial situation, although it was prescribed. And again, you see in some countries for various medical types of services, sometimes over 10% of patients indicating that they skip on certain treatments due to the socio-economic consequences of their cancer situation. A last slide is the regression analysis of the FIT score, comparing the financial strain and financial stress score as experienced by those patients, which we compared to, in this case, the Netherlands, because that was the lowest score. But again, you see impressive differences between countries on their corrected FIT scores, but not necessarily only, let's say, the eastern or southern countries scoring poorly, but for instance, the patients from Finland also had quite a high financial strain and stress score to report, as well as, for instance, the countries in the middle. So the paper that we recently presented in Lancet Oncology on consensus on the socio-economic impact of cancer and on patients and their relatives is really relevant in our view, and the OCI can produce data and can contribute to the discussion and can actually help in setting the agenda on this topic, as well as the issue of access to cancer drugs, as I indicated before. And what is of course obvious is that providers cannot change the socio-economic status of patients, but can be aware of differences and different socio-economic impact and guide patients structurally towards adequate services. And we have to develop interventions and guidance to identify relevant subgroups at risk and to counsel them to minimize these impacts. And the OCI can, as said, assist in lobby towards governments and the EU to raise awareness, adapt regulations. For instance, there should maybe be an EU-wide memorandum on standards for preventing socio-economic impact, and to sponsor research programs, for instance, in the cancer mission. And that is what I wanted to say. Thank you.
Thank you, Wim, for this very important talk and the very important work you do with your working group. So unfortunately, we don't have the time to continue discussion here, but you will meet Wim on lunch. So I suggest that we give our thanks to all of the 5 speakers for this excellent session.